Welcome to Macomb on the Move. My guest today is Dr. Jack McPherson, Director of Hospitalist Services at McDonough District Hospital and also Coordinator of Inpatient Services. Jack, welcome.
Thank you.
Good to have you here.
Good to be here.
Let's talk a little bit about, we were talking off camera about family practice and how it got started. You were the first one here of the trio.
I was. Actually, back in the mid-'70s, I was a resident with Dr. Baker and Dr. Iverson. And Dr. Baker and I had decided we were going to try to find a place we could practice together if we could agree upon the same place. So we actually looked at a lot of places. I was from Illinois. I thought Illinois had invested a lot in me, and my wife was from Illinois, so we decided we would stay in the state. So I looked at about 15 or 20 different practice locations, had a long list of things that I thought would be good criteria, like a university, a YMCA, a place to work out indoors, a nice school district for my kids to grow up in, a certain size hospital that would allow us as family docs to practice in the way we wanted to, do things like deliver babies and things that some hospitals would not allow you to do. Macomb hit all those things. The day I arrived to visit here, the YMCA had their grand opening, and the hospital was building an office building across the street, and I'd been driving around Chicago and Rockford for a number of years and was tired of being behind the wheel and was anxious to be able to walk across the street and get to the hospital. So everything fell in place. So I went back and convinced Dr. Baker to come and look. The two of us ultimately decided to come here. Dr. Baker, or Dr. Iverson, was not sure what he wanted to do, so he stayed and taught for a year. After Baker and I were inundated, after about 3 months, we decided we needed more help, and so we began working on Dr. Iverson to get to join us.
So when it was you and Baker, what were your initials?
Well, that was part of the problem. We needed another person because we had been known as the BM group. And no one wants to be the BM group, so we added Iverson so we could be IBM.
And then over time, you've added people to the group and folks.
Actually, after my initial visit here, I've always said I added 9 people. That includes Dr. Baker and Dr. Iverson. And we kept all those people except for one. We had one person whom we did a poor job of satisfying the spouse, and we lost that one person, but everyone else has stayed and still contributing to the community in some ways.
What are your fondest memories of family practice?
I really liked working for myself. I've never been great at working for someone else. I like being my own boss, and I did a lot in terms of the management of the practice. I also just had fabulous patients. There's nothing better than having your own group of patients and knowing them well and being able to care for them and being hopefully important in their life, and they also being important in your life.
Why'd you leave?
Well, I had a lot of things going on at the time. I had a grandchild who was ill, and I knew was going to probably be in and out of the hospital at least, and it was busy. I was finding myself weighing a lot more than I needed to weigh in terms of pounds and working out less. I'd always played sports in my life, and I'd always worked out a lot, but I was finding less and less time. I was spending too much time doing paperwork and things that no longer were enjoyable. So I decided I needed to do something else. And so I left for a few months, but I did have another job to go to at the university. And then ultimately the hospital called and said, hey, we're starting this new program. Would you be interested? So I started doing a little bit of working on some long weekends as a hospitalist, and that fit my needs very well. So
when you gained that extra weight, did you use that on the basketball court against little guys like me to try and move inside when I was trying to guard, unsuccessfully guard you?
I always had a reputation of playing what I called strong basketball.
Strong,
I
really?
usually began each game by wasting one foul to make sure that the guy who was guarding me was looking for the next time when he was going to get it.
Dennis Rodman, for heaven's sakes. Think about that.
Well, I was Dennis Rodman in some respects, but I could shoot the ball. And Dennis
Yes,
Rodman
you could.
never shoot the ball.
Yes, you could. But I get different stories. My dentist is Spoler, and when I'm in the chair with him, he says, I used to kick Jack McPherson's tail pretty good. And then I talk to you, and you tell me that Spoler couldn't hold a candle to you.
Well, the real story is that when I went to medical school, I had a friend who was a year ahead of me who had been at North Central College, where I'd been. And he was actually a swimmer and not much of a basketball player, but he recruited me to play on his team. We had a very small gym at the medical center, you only played 4-man basketball instead of 5 because there wasn't room for 5 people on the floor. The medical students had never, ever won the championship there. But my freshman and sophomore year, the team on which I played, not my team, but the team on which I played, won the championship. And we actually beat a team that Jerry Spoler had together each of those championship games. So the real story is Jerry got shut down very badly and his team lost. And it was the first time a medical school, we had a big medical center. They had pharmacy students, dental students, graduate students, a variety of people. But the medical students had never won until that time.
But I'll bet if I asked you what you had for lunch yesterday, you wouldn't know the answer.
Whatever it was too much.
but you remember those games 40 years ago. High school is downstate. What was the name of the high school?
Oh, I went to a massive school, Ziegler-Royalton High School.
How many kids in your graduating class?
Well, we consolidated with Royalton. I was just from Ziegler when I was a sophomore.
Yeah.
So it really bulged our numbers all the way up to 49 when we put the 2 schools together.
Okay, so I assume you were a big star.
Well, I was successful, yes. So.
It just doesn't seem fair. I went to a high school with a graduating class of 624.
Yes.
So it was a little tougher to make the team than a school of 49.
Well,
you probably had the janitor play on the team, and some kid who was out farming, he'd come in and play.
The thing that helped me most when I was a senior, the Evansville Courier from Evansville, Indiana, had a huge sports section. And they covered Southern Illinois basketball, which back in the 50s and 60s was really the hotbed of Illinois basketball.
I remember fondly watching the Collinsville and the Jayhawks was...
They're from Collins.
I mean, and who were the Orphans?
Orphans were from Centralia.
Centralia. I mean, every year poor Centralia would go up against Collinsville in sectional and never get past Collinsville because they had those great teams with Bogey Redmond and Freddie Riddle and gee whiz.
There were some great teams there.
Yeah.
But anyway, the Evansville Courier, when I was a senior, named me to the top 15 players in Southern Illinois. Within about 2 weeks, I had probably 50 or 60 letters from a variety of places, but this coach from North Central, which I'd never heard of, kept calling me, called my coach. So I didn't really know what to do. My parents were not very sophisticated about college education, so my older brother said, hey, let's go visit. So I went to visit, and I decided I would go that day. And a lot of good things happened there. I got to play a little basketball, met my wife there, got a good education, really enjoyed North Central a lot. I've sent a lot of students to North Central along the way.
And where's she from? What?
My wife is from a little town called Richmond.
Oh, yeah.
Richmond's just south of Lake Geneva, but on the Illinois side.
On Route 173.
That's right.
Yeah, because my Diane's on the other end of 173 in Winthrop Harbor, right by the lake. So absolutely. All right, so what's a hospitalist?
Well, a hospitalist has evolved in the last 15 or 20 years. If you read all the ads for hospitalists, they usually ask that you be board certified either in family medicine or as an internist. So there's not necessarily a specialty in itself, although when you look at young docs who are going through training, they are beginning to decide if they're going to be outpatient doctors and have an office, or they're going to be inpatient doctors and work in a hospital. So they're kind of focusing on that. But anymore, no one wants to do both jobs. And one thing we found ourselves in a position here was that we could not recruit doctors because we always had a system that we all went to the hospital in the morning, saw our patients, went back as many times during the day as you needed to, and worked some pretty long, hard days in the office. No one wants to do that anymore. So we found ourselves in a position where we could not really recruit doctors because no one wanted to do both jobs. So the hospital made the decision almost 10 years ago to actually create a hospitalist program. And they hired somebody to administer it, but they really didn't have enough docs, so they were always recruiting people. That's kind of how I got involved. They started calling me, and so I began to think about it and decided I would work some long weekends, and then ultimately I began working 1 week per month, which is what I do now.
So how many days a week would you work?
Well, I work all 7 days in a week, and we work 7/24s, which sounds a little bit crazy. 7/24s is 168 hours in a row. But we have some help. We have some nurse practitioners, and they take first calls some nights. So a lot of the calls are not really urgent type things or not necessarily life-saving type things. So most of the time we have good nurse practitioners that can handle most of the calls. But they also can call me if they need help. So occasionally they have to call me, but for the most part, I can get at least 3 nights of sleep during that week, and I take the call the other nights. We work whatever it takes during the day to get the job done. The days tend to be long. We're usually there about 15 hours a day. But I like the work, and I can still be partly retired this way because when my week is done, I have a few duties, but not a lot, and I can still do the things I like to do.
What's a hospitalist do?
We only take care of inpatients, so we don't really have any outpatient concerns, which is kind of nice. I no longer have all those phone calls. I don't have prescription refills. So basically, it's a matter of taking care of whomever is admitted to the hospital. Doctors have the option to care for their own patients, although we only have one doc who does that now. So basically, everybody who gets admitted to the hospital, in McDonough District at least, gets admitted to the hospitalist. So we go see that patient, evaluate them, do what we would term their history and physical, make decisions about what we're going to do in terms of testing, what we're going to do in terms of treatment. Decide if we need other docs to consult and try to get those people involved if we need them, and basically manage the patient during their hospital stay.
But if I go to my GP and he refers me to the hospital, that's where you take over?
It is, yes.
Or do people go directly to the hospital and you're there?
Probably about, I would say more than 90% of our admissions actually come to the emergency room because that's what people who tend to have acute illnesses, that's where they tend to seek care. We do have an occasional physician who calls us from the office and say that they have someone there that they think needs to be admitted. As long as the patient meets criteria for being admitted, we would take them out of their office and just directly admit them.
So what do you do with me? I'm a patient at McDonough District Hospital, and you're assigned to me. What do you do?
Well, we have to establish some rapport pretty quickly. One advantage I have is that I know a lot of people in the area, and a lot of people know me, so it makes it a little easier for me. Even if they don't know me, they somehow know of me. They've seen my picture on the wall in the post office, you know, those wanted posters they put up or something like that. So to some extent, they at least know of me. Maybe their family members know me, or sometimes somebody tells me that, hey, 40 years ago you delivered my child or whatever. They look a little different, so I don't always recognize them. But at any rate, I have that advantage, so I know those people. I had a big practice when I was here. But I also knew most of Dr. Baker and Dr. Iverson's patients, particularly if they had people who had significant medical problems. I usually knew them. So I see a lot of people whom I've known, at least on the periphery, for a long period of time. If I don't know them, I meet them, and we try to do what I've always done, try to establish a quick rapport and try to get their trust and try to explain to them what I think is wrong and what we're going to try to do to help them, and hopefully we can make them feel good about what's going to happen.
I walk around town a lot. I kind of like you, have been here forever, and so you get to know a lot of people. But I tell you what, it's and I hate to give you a compliment. It pains me. But I hear so many wonderful things about Jack McPherson as a hospitalist. I hear positive comments all the time about what a great job you do and your bedside. It hurts me to say all this, but about your bedside manner and how caring and wonderful you are. I mean, you really must have found a niche that really is working for you at this time in your career, because you're apparently very good at it.
I'm really not doing anything different than we ever did. And my partners all did that as well, too. You knew Dr. Iverson very well, and you would feel the same way about him. And I would take Iverson and Baker, and Dr. O'Neill's getting ready to retire. I'd take all of them back if we had a place for them to work and they wanted to work. But they decided they liked being away from medicine and retiring. Dr. Baker likes being on the farm. So.
By the way, did I say that just the way you wrote it for me? Did I say all those nice things? Tell me, how did this hospitalist program, how did it evolve? How did it happen across the country?
Across the country, I think everybody made the same decision that people we were trying to recruit. They didn't want to be involved in both places. Doctors have changed. I probably worked too many hours. I used to oftentimes work all day, go home in the evening and see my kids and get them to bed and go back and work again. I often, on my day off, would have to spend a lot of time working, spend a lot of time on weekends. So I spent a lot of hours practicing medicine and worked my family in between that. But the modern doc is different, and they really want to have hours, and they want to not have a lot of nighttime responsibility. And so in order to do that, they've gotten rid of the place that you get all the nighttime calls, which is usually the hospital. And if you've ever tried to call a physician now, it's a little more difficult than it used to be. They do have a call system, but quite often you get a nurse who's a kind of a triage nurse that you're talking with. When you called family practice years ago, you got whichever doctor was on call, and you could discuss your problem with them, and they tried to make some decision about whether you needed nighttime care or not.
When you were at family practice, were you able to still attend all the basketball and baseball games that the boys played?
Baseball was always the hardest because baseball took a long time and baseball was very weather dependent. So I have to confess, I didn't try to make every out-of-town baseball game. I made every in-town baseball game. When they were in Little League, it was really easy because those games were timed and we were done within an hour and a half or two. And I knew when the game was going to start, and I pretty well knew when it was going to end. And so many times I would go to the ball game and then go back and finish my office schedule. And they were all games in town, so it was pretty easy. High school basketball, I'm not sure I ever missed a basketball game. I think that I was always able to arrange my call schedule. It was nice having 6 partners, so I really only had to work every 6th weekend. And I could try to take a weekend when we had a home game, so I wasn't out of town or anything like that. So I don't think I missed a basketball game.
Great fun. What's the percent of inpatient people taken care of by hospitalists versus people who are private caregivers?
I looked at this a couple of years ago. I was giving a talk to the Rotary or somebody. At that time, about 85% of patients across the country were cared for by hospitalists. Everyone in Macomb initially was adverse to what we were doing. Patients did not like the system. They wanted their doctor to come and see them. They've gotten better at that now because I think everybody knows this is the way it's going to be, and it's been this way for about 8 or 10 years now. But across the country, they would not really see their own doctor either. They would still get a hospitalist. One nice thing about Macomb, you get the same hospitalist for a week, so if it's somebody that you get along with, it works out pretty well. If you dislike them, I guess it's not the best thing in the world. But if you were to Peoria, you might get a different hospitalist every 12 hours.
Oh.
So you may get a lot of change in what's going on. You may get a different attitude. You may get a different opinion. You may get a different treatment plan.
How long are most people in the hospital for a stay? How long what's the average stay?
Well, the average stay has gone down a lot through the years. You know, back when we were young docs, there were no regs. So if you wanted to put somebody in the hospital and keep them 2 weeks, you could do that. Now we have a lot of people reviewing this. So you kind of get asked when the patient's admitted, what's your plan, what's your anticipated length of stay. In fact, we do different types of admissions. Some admissions are just observation admissions, which means we think it's going to be something we can solve overnight and maybe have the patient out the next day. So we kind of make decisions based on information we have initially, what kind of admission they might have. But we, for the most part, have most people out within about 3 days. We occasionally have that outlier. Recently I had somebody that was there for over 20 days, but that's not very common. So for the most part, we have short stays.
Do people go to med school now to become a hospitalist? Is that coming, or do they go to be whatever?
Anyone who wanted to do that would probably be a family doctor or an internal medicine physician, and then spend their time while they were in that residency focusing on inpatient work, so that they felt like they were prepared for it.
What's the work shift? You said 7 days? Is that the way?
It is here.
For everybody?
I don't think anybody else in the country does that. Probably we do 7/24s here, partly because it's not very practical for anybody to just be here 12 hours at a time. We get some nighttime admissions, but we don't get a dozen nighttime admissions like you might in Peoria. So we don't need somebody to be there all the time. And most of the time we can deal with what the emergency room doctor has done for evaluations and make a decision about treatment based on that. There are times when if I can't decide what's wrong with the patient or if they're ill enough, I just get up and come and see them in the middle of the night.
What's a nurse practitioner and what do they do?
Nurse practitioners have become very common, and we actually have 2 excellent nurse practitioners. We have Megan Clemens and we have Jody O'Rourke. Jody's been with us about almost 6 years, I think. Megan's been with a hospitalist program perhaps 2 years, but Megan's well known to us. She was an ICU nurse here for a long time, and she was actually in the clinic for a year or 2 before she joined us. They've been really excellent. They're well trained, and we spend a lot of time trying to get them acclimated to medicine in the hospital versus outpatient medicine because they're different. But they all start out as being RNs, but they go back and get an advanced degree, usually a master's degree, and usually in a nurse practitioner program. So there are a lot of nurse practitioner programs across the country. Jody did hers somewhere in St. Louis. I think she did it at Barnes, and Megan, I think, maybe did hers through St. Francis, but there are a lot of online programs. We have a lot of nurse practitioners who come and spend time with us just to get clinical experience while they're in training. So we've had some in the local community have done that. And it's always fun to have someone as a student. We have medical students, we have nurse practitioner students. Occasionally we have just somebody who thinks they might be interested in medicine who wants to spend a few days with us to see if they think that would be a vocation they would pursue.
How long are you going to keep doing this?
I get asked that question a lot. I guess I always ask the question, do you think I need to quit?
No.
It's hard to quit practicing medicine. And to some extent, retirement can be overrated. I'm not very good at sitting around and doing nothing. I always have a list that when I take 3 things off, has 6 more things added to it, it seems like. And I have to confess, my wife doesn't add all those.
I was just going to say, who adds those on, or you or Kathy?
I add a lot of those myself. But I always have something to do, but I always am ready to go back to work. And I still really enjoy the interaction with patients, and I still enjoy trying to figure out what's wrong with people. I will be the first one to back away if I think I can't do the job right anymore. I have some standards that I won't let go. So I would never have left family practice 13 years ago if I didn't think I could retire, so I could retire again if I wanted to.
How about COVID-19? How's that affecting the hospital?
COVID-19 has changed all of our lives in about every way possible, I think. Certainly we think about every patient now, whether they are a COVID risk. So whenever I admit anyone, whether they have a respiratory infection or whether they have something else wrong, my question always is, do I need to consider whether they could have COVID-19 as part of the problem? We're very liberal about whom we test. We test not everyone, but almost everybody who comes to the hospital, just to make sure that we're protecting staff. One thing we cannot afford is we don't have a lot of extra people. We have 3 doctors who do this job. We have 2 nurse practitioners. If one of us gets sick and we are gone for a month, that puts a big dent in everybody else's work schedule. We have enough nurses to cover what we need to do, but we don't have an excess of nurses. So we have to make sure we're protecting everybody. So we put people, first of all, we test them, but we put them in isolation. Isolation in terms of how we would dress and how we would deal with them with gloves and what have you. Not in isolation where they've never seen anyone. And we decide whether they need to go into a negative pressure room. And then we wait to see what their results of their tests are. Sometimes even when their test results are negative, if we're still suspicious, we still might isolate them. If we think they're high risk, we still might isolate them. And we sometimes will test them a second time even.
What's a negative pressure room?
Negative pressure rooms were initially developed probably more for things like TB and illnesses like that, which we almost never see anymore. I've been in Macomb for over 40 years. I think I've had 3 patients with TB during that time. So it's not a very active disease anymore, but it's a room where actually bacteria cannot escape the room. So the pressure is maintained at a low level. There's an outflow from the room, and everybody in the room is going to be gowned, gloved, masked, what have you, to protect themselves as well. So.
What happens, what's happened to visiting policy at the hospital?
Visiting policy is pretty much no one can visit. There are some exceptions. One of the things we have done as physicians is we've decided we're not going to be in that decision-making process. It's an administrative decision. It's across the country. It's not just our hospital. And so we are allowing administration to set the guidelines about who can visit. For the most part, most families cannot visit. There are some exceptions if people are terminally ill and things like that, but for the physician to get in the middle of all that is only going to put us in a negative light. I don't want to be in a position where I'm trying to take care of a patient and arguing with their family about what they can do, so I'm leaving that to the administration to make those decisions.
What about room capacity and in intensive care units? How many of those do we have?
When I came to Macomb, McDonough District was billed as having 180 beds. 180, yes. We, even at that time, really didn't have 180 beds because we had made an ICU about 2 years before I arrived here, and that took away several wards and made maybe 6 ICU beds. Through the years, the government would make you get a certificate to build or change what you were doing or remodeling what you were doing. And part of the deal was usually you had to give up beds to get those changes. So I think probably we got down to maybe 90 or 100 beds several years ago. When we remodeled about 4 or 5 years ago, part of the deal was we dropped down to 49 beds. Now then we have added on 12 beds. The old senior behavior health center no longer is serving that purpose. As it turns out, it was very well built. It was built fairly recently, and so it could serve as 12 more ICU beds. So we're at about 60 or 61 beds if we need those now.
So if we had and we haven't, thank goodness, but if we had an influx of COVID-19 cases, we could handle them here. Up to
We could handle it here. I think our biggest challenge would not be so much beds. Our biggest challenge might be nursing staff. Second biggest challenge would be physicians, although we have a lot of physicians who have agreed to help. Dr. Biagini is a recently trained internist, and Dr. Biagini is a very good doc, even though his specialty is in gastroenterology. If we had that many COVID patients, we probably would have to shut down surgery again. So he had agreed to help. Dr. White is an orthopedic surgeon, but Dr. White could do a lot of things that would be helpful to us. Sometimes we could have people do work together, and someone could be in the decision-making process, but somebody else could be in the paperwork, so to speak, which is all computer work now, but it still takes a lot of time. So we have the capacity. The doctors at Springfield Clinic agreed that if we were really overwhelmed, they would come back and help as well, too. So.
What's the rub between administration and physicians? Is it just they work well together? Is it?
I think they work well together. There's always been that everybody has different goals, but in the time I've been here, I think we've always been able to solve our differences and work toward patient care.
What does isolation mean in hospital terminology?
Isolation is mostly putting the patient in a situation where staff is not being exposed to anything that they might catch themselves or take to another patient. So if we put a patient just in isolation by itself, the patient's in a room that is equipped the same as they're accustomed to having it. Usually their door is going to be closed. Everybody entering the room is going to be in a gown, gloves, mask. Some people wear a thing called a PAPR, which is almost like a space helmet. You may see some of these on TV from the videos from China. They were wearing those a lot. Some of us wear N95 masks, which is just a more protective type mask. There are some criteria when you use that type mask. But that would be the biggest difference that the patient would see. And that means everybody entering the room would be dressed like that. Somebody coming to do housekeeping would be dressed like that. Someone bringing their meal would be dressed like that. We try to limit how many people have to do that, so we might get the nurse to take the patient's tray in at the same time she's taking their midday medication. Sure. So we try to minimize how many people have to gown, glove, and what have you.
So what's the scoop on ventilators? Do we have enough of those, or do we share them with other hospitals? Or?
We actually could today produce about 11 ventilators if we needed to do that. We haven't come close to needing them. When we started this process, we did actually ask for more ventilators. The state has kind of doled out ventilators based on where they're needed most. Probably this has become most famous in the state of New York.
Right.
If you remember, Governor Cuomo made a big deal about how he needed 40,000 more ventilators. Correct. I don't know how many he actually wound up getting. I think he got maybe 30 or 40,000. Never wound up using them, sent some to other states. So all of that has settled down a little bit in that we never needed the numbers that were predicted. And so we have enough ventilators to do what we need to do. If we had need, I think we could probably get more.
What oxygen options do you have?
Well, the standard for oxygen has always been a nasal cannula, which is tubing, fits in each nose, wraps around your ears. And we have wall control in every room, so you can deliver oxygen at whatever rate we need to do that. The wall flow is based on how many liters of flow of oxygen. A few years ago, we went to something called an oxy mask, which is good for people who are mouth breathers, because you can actually have a lightweight mask that you can put on their face and deliver oxygen like you can with a nasal cannula. We have some other things called venti masks, which have been around for a long time. They have slots on the side that control how much oxygen you get, and we have different levels of oxygen. We have high flow oxygen in people who really are short of breath that we might be able to use short of putting them on a ventilator. We have pressurized machines that are called BiPAP that fits with a mask that is pretty well airtight over their nose and face. When the patient breathes in, it gives them some pressure to allow them to have an easier breath in and gives them a little air pressure to give them a better ventilation. But when they breathe out, it also holds a little pressure against them breathing out so that they actually absorb oxygen a little bit better. At first, it was recommended not to use BiPAP on patients with COVID, but a lot of things have changed from what we did a few months ago, and now then we know that we should try not intubating everybody and not ventilating everybody, and we ought to try using BiPAP if we can.
What is supportive care? Do you guys use it?
Well, everybody talks about supportive care. If you read about what the treatments for COVID are, there's really not any true tested and proven treatments available. We have some drugs that we're using, but all those drugs are available under emergency changes from the FDA saying that we can use those drugs, but they have not really gone through the rigorous studies, and they've not gone through the rigorous evaluation by the FDA. So we do supportive care on every patient, whether you have COVID or not. But supportive care is all the things that make up trying to keep somebody in as good a position as they can be to get better. So supportive care includes how much IV fluids they need. Everybody has electrolytes that need to be managed on a daily basis. So sodium, potassium, magnesium, things like that are managed every day. Some people may not necessarily have COVID, but they may have other infections, or they may have COVID plus another infection. So we may be treating their other infections with antibiotics. Patients may have diabetes, so supportive care is making sure that we control their diabetes as best we can. So sometimes we do that with our own home medicines. Sometimes we do that with doses of insulin that we give based on what their blood sugar is at each meal and at bedtime. Some people might have underlying respiratory problems, so they might need nebulizer treatments. So there's a lot of things that make up supportive care, but it's basically trying to take into account all that patient's problems and trying to keep all those things in good balance so that hopefully they're in the best position to fight their COVID. In some patients, it may involve what their nutrition is. Some people will not eat when they're sick, so we try to find some way to give them as good a nutrition as we can.
Does a hospital like Madonna District have pretty much everything that a big hospital has?
Well, I've told people for years we are not the Mayo Clinic, and we can't pretend to be the Mayo Clinic. So in answer to your question, we don't have. I think we're very well equipped for a small hospital. I think we've always been progressive about trying to do everything we could here. And I think that paid off in the long run because we have the ability to do a lot of these things. But I would lie to you if I told you that there were not times when I wish I had a nephrologist down the hall that I could call, or that if there was a cardiologist here 24 hours a day rather than just 3 days a week, or if there was a lung doctor all the time. So we could use some other specialties, but unfortunately we probably don't have the patient population to ever support that. We could, if we had those other specialties, we could probably use other equipment that they might utilize. But for what we're able to do, I think we have the equipment we need.
Hey, what is remdesivir and hydrochloroquine? What are they?
Okay. These are drugs that have been on the news a lot. Hydrochloroquine has actually been around for longer than I've been a doctor. Hydrochloroquine is something we prescribe for people who are traveling to areas where mostly probably African nations. So we used to give that as a preventive drug. But also we had a lot of patients who had rheumatoid arthritis and related illnesses who took hydrochloroquine. So it's not an unfamiliar drug to us. In the lab, hydrochloroquine suppresses viruses, and it does in the lab suppress COVID-19. The real question is, can you translate that to in the patient? Does it work there? But if you were going to try to prove that, you'd have to do a long study. Most things we do in medicine are not determined by somebody doing a short study and saying, okay, my left big toe hurt and I put tape on my right thumb and my left big toe got better the next day. So the conclusion is tape on your right thumb makes your left big toe better. That's an anecdotal study. That's silly, and that doesn't mean anything. But if you had 1,000 people who had a sore left big toe and you put tape on all 1,000 right thumbs and 990 of them got better, then you might be able to conclude that the right thumb treatment worked. So we don't have that information yet, won't have that information for a year or two. So there are ongoing studies about hydrochloroquine. Unfortunately, it became a big political football. And personally, I've looked at some of the studies, and I think there's evidence that it probably has some benefit. I think that the drug has been falsely maligned because the side effects are pretty minimal, and you have to be cautious about on whom you use it. Make sure you've looked at their EKG, look at the particular segment of their EKG, look at their other medications, look at their other illnesses. But it is possible to give it. It looks like it works best if you give it early on. The drug that's getting all the press now is remdesivir. Remdesivir has been temporarily approved to be used. Remdesivir is an intravenous form only, so that makes it a little bit more difficult because hydrochloroquine is a pill. Remdesivir is also in very short supply. Hydrochloroquine is pretty easy to find. But remdesivir has become available to us. It's being allocated. We don't get to order what we want. The state is allocating it, so the state gets a certain amount. They look at where the cases are, they decide who gets it. But we did get some, and we've put in for some more, so hopefully we'll get some more. We so far have had enough to use for the patients we thought met the criteria to use it.
So anecdotal studies aren't very valid. What are lab markers?
Well, we have a lot of lab markers right now. The lab marker that's being used most, and of course there's been a lot of criticism about testing. Part of the problem was some of the early testing was not reliable and there was not enough of it.
Okay.
But viral testing has never been very readily available. When I worked those few short years at the university, when we would have a flu outbreak every year, the state would send us some test kits and we would test students whom we thought were at risk. But those were mostly surveillance type things. They wanted to know where the flu virus was. And so they were looking around different parts of the states. And so we were not testing every student who came in. For years, I practiced medicine. I don't think I ever did a flu test in my office. The flu is pretty well identifiable. And when you're in a flu epidemic, everybody has the same symptoms, so you pretty well knew what it was. For COVID, the initial testing was based on a test that looks for the actual genetic material, the DNA and RNA, and it's a nasal swab. The ones that have been most reliable and have come back to us most quickly are the ones that are going to the state labs. And they've actually done a very nice job the last couple of months. We're getting results back roughly in about a day or so. We send a courier with our tests every day about midday to Springfield. So usually by mid-afternoon the next day we know what the test results are. There is also some commercial labs who are doing this. They're a little slower turnaround. There are some new things coming down the line. There is a test now it's supposed to be a quick test to measure the antigen, and you're supposed to be able to get a result within less than an hour. There's been some questions about that test, and in fact, right now we've put that on hold. We were doing it, but we're not sure whether we should be doing that. There are some antibody tests that are basically useful to see when you were sick 3 months ago, did you have COVID-19 or did you have the flu or did you have something else? So we may be able to do those in the future to see who has some immunity indicating that they had exposure and developed their immunity to this illness.
How are you able to keep current with what's going on with COVID-19? It seems like there's something that changes every day.
Something does change every day. There's all kinds of information out there. The CDC has information, and they have information that I'm not sure if anyone can log on to it, but they have things that are made specific for physicians. IDPH, Illinois Department of Public Health, does the same thing. I'm a family doctor, so the American Academy of Family Physicians puts out a lot of information. All of us have used the last 10 or 15 years a program called Up to Date, and Up to Date basically is what it says. It's a program that any physician can use for basically any kind of medical problem. And you can go to it and it summarizes what the most up-to-date information might be. And it is truly updated on a daily basis. Initially, it was not very good for COVID because nobody knew anything. But it's become a lot better, and it's got all the information added on a, I don't know if it's a daily basis, but a fairly regular basis. And the hospital subscribes to that for the caregivers, so we can all go to that, and we all use that a lot during the course of a day for all problems. If I have somebody who has a little bit of an unusual medical problem and I need to update myself about what's the most common treatment or what's the most common test, I can go to that and refer to that. So.
What is fast tracking as it applies to vaccines?
Well, I mean, the president's used that term because he wants this fast tracked, but in the past, vaccines have been developed. First of all, there's been a lot of failures at developing vaccines. You know, for 35 years, they've tried to develop a vaccine for AIDS and have been unsuccessful.
Took a long time to get polio.
It did.
And you're sitting, two polio pioneers are sitting right here. We were right there when it first came out.
Actually, the Salk vaccine was an injectable vaccine in 1955.
Correct.
And the Sabin vaccine was an oral sugar cube inundated with the vaccine in about 1960 or 61 probably. But even things like chickenpox was only maybe 25 or 30 years ago.
Right.
So a lot of these illnesses have been around a long time. In the past, what we've done is we've taken the virus and we've either given live virus to somebody in what we call an attenuated form, or we've taken dead virus and given it to somebody and let their body develop immunity to it. What they're trying to do with the COVID vaccines, they're trying to take the genetic material and use that as a source of what you develop your immunity to. So it's a new approach, and I think it's making it go more quickly. They have one study now that's in phase 2. I think the first phase was 40 patients. The second phase, I think, is 600 patients. And they've actually shown that the vaccine is effective and that also that it's very well tolerated. So hopefully that will fast track it and make it available to us. But
what's PPE, and do you have enough in your supply?
Probably one of the other docs could answer that better, but the story I get is we have a good supply, and we now have had enough illness in the community, and we've had enough institutions in the community who have had several patients with COVID that we qualified to get more from the state. So we're getting regular supplies, and we're storing it up, and they're keeping track of how many days we have based on a certain number of patients. And I'm told we have plenty right now, but we also try to conserve it. We're trying not to send 6 people into the room if one person can do the work. I mentioned about the nurse taking a meal in to somebody who's in isolation. The sad thing is I think that patients get visited a little less often than they used to. As a hospitalist, I'm in the hospital 15 hours a day. If I had somebody in ICU 6 months ago who was pretty sick, I might see them 20 times that day, not necessarily to talk with them for 20 minutes, not necessarily to do something, but I might walk by and see what they look like, look at their numbers, say hello to them. But anymore, it's hard to do that, so I make less visits probably than I did before.
If I was in intensive care, would you have come to visit me?
I certainly would have done that.
How do you?
We treat all patients the same, you know.
How do you keep current? What do you? I mean, are you a prolific reader on this stuff? Is there literature that comes out that they tag as extremely important?
I've always learned a lot from people around me. I was one of those guys who went to class every day when I was a college student and listened to the professors, took a lot of notes, didn't always read every textbook I was supposed to. However, I got burned one time when I was a biology major, and I took a test one time and didn't read the material, and they asked a few questions from the reading material, so I learned that I needed to do that a little bit more. So I do read a lot now, but I can't take a study that's 50 pages long and try to break down the study. So I have to read people whom I know have done a good job of breaking down the study and have summarized it for me. Fortunately, as a family doctor, we have a journal we get every 2 weeks that does all that. So I can read that fairly quickly and keep up. I can use up to date, which I do a lot, and keep up. I've never been one who went to a meeting that was in some exotic place. In the last 40 years, I've probably been to the Mayo Clinic 30 times to a meeting which I think is really good and really informative. And I have to tell you that Rochester's a nice city, but it's not very exotic. And there's not anything very fun to do there, so it's mostly about medicine. So when I go to that meeting, I spend the week trying to learn something.
What is experience teaching you?
I'm sorry, what
is experience teaching you?
Well, experience is always really good. You know, when you're a young doctor, you think you know everything. But unfortunately, medicine is very humbling, and you learn very quickly that you need some other people to help you along the way. Every young doctor should have somebody who's a mentor of some sort. When I came here, Baker and I were partners together, so we didn't really join anyone else. But we had a lot of great docs around who knew a lot about medicine, who helped us along the way. Don Dexter was a surgeon, but Don was also a really good doctor.
Good man.
And I remember calling Don many times and saying, I think I know what this is, but I've never seen one before. And he'd come and say, hey, you're right. I've seen about 100 of these. I find myself sometimes telling young docs, yeah, you're right. I've seen about 100 of these. So time does make a difference for all of us. So I think experience has helped.
During my dad passed away in 1988, and he was here when that happened. Too many martinis and too many Philip Morris Commanders. And near the end, my wits about me. I met with Dr. Dexter, and I said, "What do I do?" And he looked at me and he just said, "Gordy," he said, "you've been a good son. You've done what you could for your dad, and it's in God's hands, and that's okay." And it comforted me, and it was a wonderful thing that he did. And I always remember Don Dexter for doing that.
I have a famous saying, people are always very fearful when they have somebody who's terminally ill, that they're not going to be there the moment they die, or that they're going to step out of the room and they're going to die, or they're going to go eat lunch and they're going to die. And I've tried to tell people that it's not what you do the final moment that really makes any difference. It's what you did all their life that makes a difference.
Got a guy who doesn't live here anymore, and I won't go into the story, but he every time I talked to him, he asked about Jack McPherson. You were awfully good to Jack Morgenthaler.
Oh,
you helped him out.
Jack's a good guy. Actually, Jack and I grew up 30 miles apart. I always tell him that I never played any sports against him because he's so much older than I was. But
he played 1 year with Elvin Hayes.
He did.
Yeah.
Right. He grew up in Pinckneyville. Pinckneyville was 30 miles from where I grew up. We actually used to make, before I knew who Jack was, we used to make jokes about Pinckneyville because we said no matter what year you play them, they're going to have a Morgenthaler on the team. Because they did for about 10 or 15 years running. Jack and his brother and cousins and what have you. So, but there was a Morgenthaler the year when I was a junior or senior. We played them, but it was his cousin, I think.
Did you ever play against Redmond, or did you ever play against Collinsville or
no, they were too big for us.
Too big for you?
Yes, never played against those guys.
Exercise. You know, you and I talk about this. I'll see we'll both be out walking. I go, should we be doing this? And you tell me, yes. This is the best thing we can do for ourselves at this point in our lives.
I've always said that if I could get on TV, but this may be the first time I've been on TV, so maybe I should do it right now. But if I could get on TV and everybody in the world would agree to do what I told them to do, if everybody would quit smoking, and if everybody would at least just get their weight reasonable, they don't have to be skinny, and if everybody would exercise, we could get rid of probably 2/3 of our chronic health problems in this country.
Really?
Really.
Wow.
Smoking is a terrible habit that leads to so many health problems. Lack of exercise leads to so many health problems.
So while we're on that topic, let's talk about end of life. And you're a hospitalist, and you're also in charge of the inpatient program out there. What should we be doing in terms of advanced directives and living wills and durable power of attorney and stuff like that? We should all be thinking about that, correct? And have that done. It would make it better for our family when it does happen if we have those things in place.
All of us who work in the hospitalist program for the last 8 or 10 years, whatever we've been doing this, every patient we've seen who's probably over 40, one of our questions, in addition to what's wrong with you and what's your family history and what's your past history, is we start out by something simple. Do you have a living will? And everybody kind of knows that word, but nobody knows what a living will is. And actually, a living will is not the greatest document in the world. But it's a good place to begin. And if somebody says, yes, I have one, my next question is, what does it say? And almost no patient knows what it says. So we try to look at those if they have them available. If they don't, we try to encourage them to develop one. You don't have to go to an attorney. You don't have to pay to do this. The hospital will do this free for you. And basically, what we like for somebody to do is tell us what we do if something drastic happens to you. Do you want us to resuscitate you or not? Do you want somebody to put a tube in your windpipe and put you on a breathing machine until somebody can decide whether you're going to be a vegetable or whether you're going to survive? And also, would you name somebody to be your durable power of attorney who can make decisions for you when you're unable to do that? So if somebody has all that in writing, it makes our job so much easier, and we try to encourage everyone to do that.
What's the future of telemedicine?
Well, we're not using very much telemedicine inpatient. We actually have the equipment to do this inpatient. We developed a program with SIU School of Medicine about 3 years ago to do this. We've done a handful of these. The problem is every time we had someone that we thought would be a good candidate, we couldn't link to the specialists we need, or they wanted to do it in 3 days, and for an inpatient you can't wait 3 days to do that. And it worked best if actually I went with the patient to the room where they were going to do the televisit, and I could see what the doctor was wanting to know, or he might want to know what something on the skin looked like. Perhaps I could describe that best. So it just logistically was not as good as we had hoped it would be. But there is a place for it, and of course COVID has made it much more common. They're doing it much more as an outpatient than they were. It's never going to go away. I think it's really good for rural areas. I went to a meeting in Arizona a few years ago. I did not go to Mayo Clinic that year.
I was just going to say.
And actually, they presented a big presentation about how they were going to remote areas of Arizona where people maybe had never seen a doctor, and they were doing telemedicine with those people. So it was useful under those circumstances. It's always going to have a place. To me, the best thing is to sit with the patient, talk with the patient, be able to examine the patient, be able to make a decision, decide who needs to see them, send them to that person.
Are you optimistic about the future of medicine?
I'm always optimistic about everything. Because things change doesn't mean we should not be optimistic about it. There are things I think that we change that used to be better. And there are some things that we changed that obviously are a lot better. Microwave ovens were a wonderful invention because I no longer had to go home late in the evening and eat cold food or stuff dried out in the oven. I could microwave it. Garage door openers were a great invention because when I was a kid, I always had to get out and open the garage door for my dad. But now then, you don't have to do that anymore. But some inventions have made things less personable, I think. And sometimes we have gone to systems that are all based on data and not enough talking to patients. So in that regard, I'm still old-fashioned. I still sit down and talk to the patient. I never turn on a computer. They never see a computer in front of me. I almost never write anything down. I spent a lifetime listening to people, and I've always been blessed with a reasonable memory, so I knew what they had told me, and I could then, when I left the patient, go record all this stuff. So I still take that approach.
Your mom and dad, what'd you learn? Life lessons did you learn from your mom and dad?
My parents grew up at a bad time. They actually got married about the time the Depression was in its full hilt, and they never really had good opportunities. My dad was the only male child in his family, so when he finished 1 year of high school, his dad told him he needed to go to work and help support the family. My mother's mother died when she was 3, and she was raised by an aunt who was a lovely person but never had any idea about how to raise kids. So my parents never had any educational opportunities, but they were really bright people. My dad never pushed us to do anything, but he used to put a hand on our shoulders once in a while and say, coal mining is a hard job, you ought to get an education. So my 2 brothers are pharmacists, and I turned out to be a physician. There were 4 kids in the family. We lived in a town of 2,500. We're all 4 years apart, so every time a McPherson finishes high school, you got another brat starting high school. We also all worked at the local drugstore. My sister was the oldest. She worked as a car hop back when they had soda fountains. But then every time somebody finished high school, you gave the job to your brother. So we all kind of grew up around medicine in that regard.
Why'd you get into medicine?
I always tease my brothers. My brothers were always really bright, but were not always motivated. So they were good students, but not great students. I was one of those students who was never satisfied to make an A in every course. I wanted to have a perfect test
Oh
in every
boy,
course.
one of those kids.
So my older brother, by the time I was finishing high school, and I was actually very interested in sports, and I was even thinking about coaching or something like that. My older brother told me that you should do something more, and you're going to be bored being a pharmacist. You need to do something different. And so he kind of began talking to me about medicine. So I talked to our local doc, who was just a family doc, and kind of entered college as a pre-med student. Of course, in general, there's a whole lot of people who enter college as pre-med students, and very few stick with it very long, but I did stick with it. So.
What do you do for fun these days?
I still really enjoy sports. I just can't do anything anymore, so I play a lot of golf. Doesn't always look like golf, but I still play. If nothing else, you compete against yourself. And I still play in competitions. We still have events, and I try to play in the events when I can. Oftentimes, I'm the oldest person in the event, but that's all right.
It's okay.
I can't hit it very far anymore, and I never could hit it very straight. I was never a great golfer, but I have a few things I do. I make a putt once in a while, or I make a good pitch once in a while. I really like to walk. I have a bike. I ride a bike a lot. I work in my yard a lot.
Is Keeney still playing golf? Is Keeney playing golf?
He's playing golf again, yes.
Good. Good for Jim. Good for Jim. How about you? Had a favorite movie? Probably Hoosiers.
I do like Hoosiers a lot, but probably my favorite movie was Patton.
Oh, good one. Yeah, yeah, yeah. We all know that famous quote. We can't say it on the air here. Hey, if you could go out for dinner with some famous person, deceased or alive, who would that be?
Bob Gibson would be one, the pitcher for the St. Louis Cardinals.
That's why the mound got lowered.
Lowered.
Yeah.
That's right.
Yeah.
Yes. Bob Gibson, actually, everybody knows Michael Jordan, and I think Michael Jordan was a great athlete. And I always said Michael Jordan was great because he made everyone else around him better. He took people like Steve Kerr and made them professional basketball players. Luke Longley, who couldn't walk and chew gum, and made him a player. But Bob Gibson was probably the world's best competitor, and I always wanted to be the world's best competitor. I lost a lot of sporting events, but when I lost, I wanted to make sure the guy that I played against knew that he had been through a battle.
You were successful. Yeah, trust me, you were successful. You did a great job. I still have probably limbs. That's probably why I had to have my shoulder replaced, for heaven's sakes, because you taught me that lesson. Yeah, absolutely. Gibson, obviously we both know the answer to this, but he owned home plate.
Yes, he did.
That was his. If you got too close to home plate, Bob Gibson let you know that it was his.
Yes, he did. And he played against all odds. He was an African American back at the time when they were not being paid very well and they were not given opportunities. And, he was a great athlete. He played with the Harlem Globetrotters.
I didn't know that.
And he went to, he was from Omaha, so he went to whatever universities there. Is that?
Creighton.
Creighton, yes, Creighton. Played basketball there. And, for years he was actually won Gold Gloves as a fielder. And he actually was a very good hitter. And, he actually broke his leg in 1967 with a batted ball, and he pitched 2 more pitches after that with a broken leg before he decided that
maybe it's time.
Maybe he's good out of the game.
Yeah.
So.
What are you proudest of?
My family. We've had a great opportunity. We had 2 boys who were great. We have 6 grandchildren, and they've all done well. And I always tell them that I'm always proud of them, but I'm always happy for them as well too.
Now, your boys, one of your son, Brett competed with Gordon, and they made quite a tandem in high school, trying to decide whichever one of them took the ball out of bounds, the other one didn't see it.
Well, I always tell my granddaughter, who's a pretty good athlete, that your name is McPherson. You're supposed to shoot the ball. And I kind of raised my boys that way as well, too.
Yeah. And son Derek, I tell the story, our youngest was very close to him, and Ryan was a freshman when Derek was a senior. And when those things would happen in high school that happened to kids, all Ryan had to do was look around, and there'd be Derek McPherson looking over his shoulder, whoever was giving Ryan a hard time, and it was over. Derek was always there. People was talking about it. Derek was always there to take care of Ryan Taylor, and Ryan Taylor never forgot that. He was a wonderful young man.
Derek always loved little kids. When he was, we had a paper route when the kids were younger. It was we lived in Hidden Hills, so it was a contained neighborhood. And when Derek would deliver the paper, there would always be 5 or 6 little kids working for him, probably for no pay, I would guess, but they just liked to do the paper route with Derek. When Derek was growing up, he would work at the Y, and there would always be kids there when he was scoring. And likewise, when he was a young adult, when he was coaching teams, there were always, probably at his funeral, I would say there were probably 300 kids who came through who said that Coach Derek had been their coach somewhere along the way. So.
Wonderful, wonderful young man. What do you hope your legacy is going to be, Jack?
Well, the most important legacy would be that your family thought that you did the right things for them. But I've always tried to, hopefully, I've tried to make patients feel like I did the right things for them, and I've tried to make medicine better for McDonough District and Macomb. I've had opportunities to do other things, but I've never chosen to do those. I wanted to be right here. So.
Well, we're glad you made that decision to stay here, and as I said at the outset, you're extremely well thought of by your patients out at McDonough District, and I'd love to shake your hand, but my wife would not speak to me for a long time if I did, not for the reasons you might think, but I appreciate you taking the time from your busy schedule to be here with us today on Macomb on the Move, and to you folks. Thank you for watching us. Thanks for joining us today, and we hope you learned something about COVID-19 and how we're dealing with it in this community. And thanks so much for watching, and have a great day. Take care.